Good afternoon to all our participants, and we would like to welcome our leaders from Lao. So this afternoon's training will be facilitated by Mr. Siddharth Srivastava. And before we begin, may we call on Ms. Christine Pascual to briefly introduce AHIN.
Hi everyone, can you hear me?
Yes.
Hello everyone, so we would like to welcome the participants from the National Health Insurance Bureau, as well as from the Swiss Red Cross. So before we start, we would just like to introduce everyone to the Asia eHealth Information Network. So we are a network of about 1,000 eHealth practitioners in the region, and most are members of the Ministries of Health from different countries. So in AHIN, we promote best practices on gaps, or what we would like to call governance, architecture, standards, and program management in implementing national e-health strategies in Asia. So part of this effort, of course, is our existing partnership with the openIMIS initiative to build and expand a growing community of practice on openIMIS, especially on the use of ICTs for health financing and insurance management. So we would just like to thank Dr. Bunfeng and Dr. Buafat and the rest of the NHIB for making this online training possible. So we hope that at the end of this training, we will be able to impart insights and knowledge that will help support your country's health insurance management, especially on claims processing and reporting. So I guess that would be all from Ian's side. Chat.
Yes, thank you, Tin. Now we would like to call on Mr. Saraf Bataray to introduce the openIMIS initiative.
Good morning and good afternoon, everyone. On behalf of the openIMIS community and from the openIMIS initiative, I'd really like to welcome everyone to this first in a series of webinars aimed at providing information on openIMIS, the tool as well as the business processes that are supported by it. We really hope that you're able to learn about the capabilities of the system and can think of ways as always, please feel free to ask questions during the session and even beyond. If there are any queries that come up after these sessions, please feel free to reach out to us from the openIMIS website, openimis.org, or through our wiki, or through our friends at AHIN, whatever is easiest for you, and we'll make sure to follow up. I would like to give a special thanks to the AHIN team for organizing these sessions, and hope to see you all and more in the sessions to come as well. With this, I hand it over to Siddharth, Health Financing and openIMIS expert from the Swiss Tropical and Public Health Institute, to take it away. Over to you, Siddharth.
Thank you, Sir Sarav and Sir Siddharth. First, we would like to hear from Dr. Buafat and the Lao leaders on their expectations in this openIMIS training.
Yes. Good afternoon, everyone. First of all, I would like to thank you for AHIN team and your team for providing us opportunity to join this course. I think this course is very important for us because now we established national health insurance since like nearly 4 years ago now, and we have a lot of challenges, especially about database system, because we still working on database system and try to improve the system of management on especially for reporting system, claiming process, and other function of health insurance. So we have a lot of things to do now. So we hope that this course would provide us more understanding on, especially on database system, openIMIS system, and also how to link the system with our existing system and how to improve our management system. So today we have many people of our staff that from different division, especially we have from IT division, IT unit, and also from auditing division and also financial unit also. So I think we hope to learn from this course also. Thank you very much.
Thank you so much. May we now hand over to Sir Siddharth to begin the training.
Thank you, sir. Hello, everyone. Also, a very warm welcome from my side. As Sarah mentioned, I'm Siddharth Srivastava. I'm based at the Swiss Tropical and Public Health Institute in Basel. And we are working with the initiative a lot around the capacity development side. So as Saurav mentioned, this is a series of trainings that we were undertaking on basically introducing openIMIS to different participant groups. And as part of that, I've tried to adjust a similar training which we were running on other days, especially now for the discussion. I'll try to hopefully also very much keep it related to the expectations from the training, but maybe one thing to just flag is really this is the starting point for us really. As you see here, the session 1, which it says here, the introduction, this part is really firstly to find a way to relate really to your context. So the idea was to start with a broader broader scope of health financing and within that where health insurance schemes fit in. And then go into really the actual software. So the understanding on the software, as you mentioned in one of your expectations, will be mainly starting from session 2 onwards. And then subsequently next week, the other 2 sessions, they are also very much focused on the actual software. And also the audience, as it's mentioned, there's people from the IT division, auditing division. It's very much going to be from a user perspective, user of a system, talking about insurance processes, etc. And but in the Q&A, etc., if you can please feel free to raise questions, whether it's related to the sessions or outside. And since Saurav is also here, the 2 of us will at least try to answer your questions, including technical ones, as much as we can. One more small thing I would ask is I had a brief look at the video, and I think the colleagues from the Health Insurance Board, I'm not sure whether people would have also a computer. The way we organized the sessions was to also allow us some time to actually do some hands-on work, so really practice with the software. Session 1, we won't have that, but session 2, in the second hour, I would have hoped that you would have a computer so that you can really try it out from your side. And that's really the best way to know any kind of software application, is to just try it out hands-on. So I would really encourage, if possible, that you all also have your separate laptop so that you can, with the internet connection, so that you can log on to the website details, etc., which was circulated to you earlier on, but also I'll show it again here. That would be one small request to some of the participants who don't have perhaps a machine to themselves.
Yes, we will prepare for next session.
Perfect. And as we said, it's not a lot of people in the group that I see. I mean, separate users. So I'll explain it as we go along, but maybe some of the discussions we can just have it open as you did now. Just please stop me at any point, raise a question. Otherwise, there will be specific points where I'll try to pause, but otherwise you're free to do both. You can type in a question in the chat. Otherwise, just stop me at any point.
Okay.
All right. Perfect. So let me just start. This first session, essentially, like I said, here the hope was that at the end of the session, we talk a little bit about health financing concepts, which right now I won't. Also in the because we have a little less time right now. And I think all of you are working in this in the health financing space, so you have a general idea of health financing concepts. You've had your own exposure with different health financing interventions, health insurance and others. So I will mainly focus on really the transaction level. So around health insurance, talking in general about what kind of transactions are generally there with health insurance mechanisms, which you will probably find some bits which you can relate to, maybe some bits you can't, and then have some small discussion around that. So that's really going to be my starting point. And like I said, there will be these two blocks, which I'll try to cover. How will the session run? This is what we shared with you before, but I think I'll adjust this a little bit as we go along, just to manage the time a bit better, and also with regard to the number of people that we have. One thing I would flag is we try to make it a bit more interactive. So at some point you will find, so block 2, for example, you will find some polls which will pop up on your screen. Please do respond to them. It's also a way to kind of relate to the discussion that I am having, as well, for us to kind of reflect back a bit. And as I mentioned before, please do type in any questions at any point. But we hope to kind of structure the first hour. This is session 1. And in the second hour, I will explain after this. I wanted to start first this whole point of trying to reflect with another context, where there's really a mix of different financing mechanisms. And I would like you to also just reflect in your context what this really means. So this is a very general diagram which is used quite a lot by WHO. It helps you really understand the revenue flows, really from the point, the source directly to the pooling entity. So you are all aware, you have in your context also probably similar kind of splits, the public sources and the private sources. You have different forms, as you have the national, the health insurance board, which you have. I'm guessing it's a autonomous public agency kind of a setup, but you also might have other forms. So just to give you an example from my exposure in Tanzania, there's of course the private side. You are all aware of this. There's also the out-of-pocket expenditures, which happens at the point of care. So there is user fees as well in Tanzania. So apart from the different financing mechanisms, insurance, etc., there's of course this standard approach where if you go to a public facility or so, there's a price which is highly subsidized, but still there is a price which is placed on different services, which then also have their own exemptions in their context. So older people, under 5, etc., some groups get certain exemptions. So there's that financing mix. Then they have what's called the National Health Insurance Fund. So this is really the formal sector insurance scheme. I am sure you have that in your context as well, where employees of government organizations, actually even private organizations, they're mandated to be part of this. It's kind of mandatory for them to be part of this health insurance scheme. They also have what's called the Community Health Funds. So this is something which is at the regional level, government body which is mandated to create these community health funds, which is a health insurance scheme primarily targeting the so-called informal sector. So this is a voluntary scheme, so people can decide whether they would like to join or not. And it's a similar insurance program, but the difference being the National Health Insurance Fund is a single national agency, whereas the community health funds are run under a region. So there's 26 regions on the mainland. There's 26 different insurance schemes which are running for the informal sector. In addition, there's also, of course, also a lot of private companies, for-profit insurers, whether they are local, Tanzanian, or regional, East Africa based or so. So there's different forms of insurances basically there. And of course, in addition to all of this, there's also the not-for-profit insurers, church-based charitable health facilities who are offering this, NGOs, savings group, etc., more the community-based health insurance forms, which I think also at some point were there in your context as well. And having said all of this, there's also the so-called voucher program, which is now incorporated further into the National Health Insurance Fund. So it's kind of added as an additional product, which is also offered by National Health Insurance Fund, but just targeted for pregnant women. So while there are all these different range of different sort of prepayment forms of prepayment financing mechanisms, mainly around insurance. There's also now a strong drive to move towards what's called a so-called single national health insurer. The essential idea being really to bring the pooling together, to really unify, to create a strong kind of single purchaser which can purchase services from for healthcare provision then. And this is kind of the direction where things are kind of going. And the idea here was to just kind of give you some background or some way to relate a little bit in this context. And maybe what I would ask is, I mean, let's not do virtual groups or so, but since our colleagues are already here from the insurance board, for example, maybe we can start there. There's obviously the health insurance form which you have, but maybe we could just do a quick kind of stock taking, which you can give a feedback to me on in your context. What are the different financing mechanisms that you have in play right now? Do you have user fee, for example? Do you have other private insurers, etc.? Just to get an idea of where you really stand. And this was really from the perspective of the revenue sources, so who's actually paying into it, and the organizational form which is doing this this role of pooling and then purchasing services. So maybe I would just open the floor in a way and ask you to perhaps just contribute from your context what kind of financing mechanisms that you have in play.
Yes. Would you like to say something about the system account? Okay. Maybe I can have some response on this. Yes, because in Lao now we have national health insurance that is tax-based system. Yeah. But we collect a little bit co-payment when they come to use the service. And we have formal health insurance system that are from government, staff, and enterprise sector. That now we try to integrate in one umbrella under national health insurance now. So even we have a tax-based system that the government pay about, now it's about 90% that government pay and 10% that we collect from co-payment now for the informal sector people. But for the formal sector, still have 50-50 from the government and from the employer and employee. Yes. But we still have one area, we still have a community-based health insurance that voluntary system. Yeah. Voluntary scheme. Yeah, that 50% collect from people and 50% from government. This one. And according to the utilization of the service, we still have a lot of people that pay on out-of-pocket payment also. So, but we still have a lot of private health insurance, but those private health insurance are not managed through national health insurance. National health insurance just manage total population, but people who enrolled in the private system not yet enrolled, not yet managed under national health insurance.
All right. Thank you for that. Do you also, you mentioned somewhere that people do have out-of-pocket expenditures. So this is in context also of sort of user fees, which means if someone is not part of a private insurance, they are not part of the NHI system, the formal sector scheme, or the voluntary form, they would pay something at point of care. That's what you meant.
No, we cover everyone through national health insurance tax-based and through formal health insurance. Yeah, this means that according to this, 100% is already included in the system. In the now the system with national health insurance system now. Yeah, but according to our system, that we still have some like exclusion. The benefits that the benefit of health insurance still have some exclusion that people have to pay by themselves something, especially for VIP room, for example, and other other service that not covered by health insurance. Yeah. But still, we have problem with a lot of people uh, don't have any document to identify that they are in the system in the catchment area, so they have to pay by themselves something there. This one is out of the capitation co-payment payment. They still have to pay something there, especially for people who cross the border. Another one that when they because we have the main contractor for them, we have the gatekeeping at district hospital, for example. If they cross the border to provincial hospital, they have to pay by themselves, for example, something like that. Yeah. So, but now because of our system maybe it's not good enough to identify those people. So still a lot of people they have to pay.
Okay. Okay. So it's kind of in a way mandatory for everyone to be in one form of insurance or the other, but still there are payments at the point of care, as you said, in form of copay. So if they want to get an upgrade or whatever, they have to pay extra as well. This kind of cross-border population. So
Yeah.
those who are not falling under the insurance, they might have to pay at point of care. So that's what you meant in terms of
Yes.
out of pocket. Okay. All right. And are there any kind of targeted forms, for example, vouchers or so, any special programs which are also running in addition to the insurance programs which target specific groups? Or are they part of the insurance as well, or of vulnerable groups or so?
Yeah, before previously we have the voucher for pregnancy women and children, something yet. But now we integrate all the system because in Lao before we have community-based health insurance for the informal sector. We have health equity fund for the poor, and we have pregnancy policy of free care for pregnancy women and children under 5. So we have some voucher for like in order to encourage pregnancy women to use the service something. But now we stop all this because we provide them with for the poor. Now we just provide them for transportation and food allowance something. But we don't have a voucher system now.
Okay. Okay. I guess, I mean, I just try to relate a bit also to my exposure and context. So I guess there's also this kind of unification in a way going towards broader, and that's also the reason where you say the formal sector, informal sector is kind of merging under this national health insurance body, and vouchers in the past, CBHI, Health Equity Fund. So really this kind of merging into a more central kind of single national purchaser role. All right.
And the one
Yeah.
that we have a national health insurance system that collect co-payment, a little bit co-payment from general population, but we don't. This one is except for this exemption for the poor and for pregnancy women and children under 5. They don't have to pay co-payment. And for the formal sector, because of formal sector, they already pay contribution, so they don't have to pay co-payment also.
Okay. All right. All right. That's thanks very much for sharing that. I don't want to leave anyone out. I don't know if I saw institutionally there was also Swiss Red Cross as well as ILO. If anyone else wants to add anything? And if not, please also feel free to add in the chat, and we can pick up some points later. All right.
inside.
Okay. Let's. I mean, my intention of doing this was just to find a way to really relate. And what I would ask you to do is maybe just already think a little bit about now in the next set of slides. I wanted to go more in details about transactions. So if you can think the different mechanisms that you mentioned now, if you can just think in that context and I mean broadly around the insurance context and how the functioning happens. So the different roles, processes, etc. That's basically what I will also now talk about. And what I will do is I'll try to be a bit more generic, but obviously this is really very health insurance specific. And right now, again, I'm not talking about the software. This is in general, finding a way to relate from the point of view of what processes are there that require digitization, and then going into, in the next session, in the next hour, into the software and how it addresses it. So right now, it's just about, in a broader way, how health insurance systems function. And you will obviously find ways to really relate to it. So there will also be these polls. Please do respond to that. And try to reflect a little bit with what I'm saying and your context here. So in a general way to start with, we always have this kind of a form with this kind of a triangle with three key actors, which is on one side you have the so-called purchaser, the insurer, etc., the agency which is doing the pooling aspect, as well as the purchasing of health services from providers. And then you have clients in the midst of all of this. So what you have in terms of transactions happening is really firstly quite a lot around the purchaser side. So you obviously have some kind of structure in place on the purchaser side. I think you also have colleagues who are there from the IT departments, from the auditing, the claims verification, etc. That's basically your different structure which you have within the purchaser side, different actors who have different roles to perform. You then have the healthcare service provision side. So here you have obviously service provision being done at different types of facilities. So you can have dispensaries who offer some care. Maybe you then have higher level health facilities, hospitals, referral hospitals. So you have some kind of a level there where different facilities offer different kind of what we call services and items. So the kind of things that they offer might vary across different levels. And then you have also what's called the price list. So you will also have cases where obviously certain services and items might also vary in terms of price across different facilities. A simple example would be a difference between, let's say, a government facility and a private or a charitable facility. You might have the same service being offered, but perhaps at a different price. So that's what a price list is. And then you have some kind of contract, some kind of agreement which is made between the purchaser and the provider. So you have some kind of arrangement which you make where you say what will actually be paid for by the purchaser, at what prices, are there co-payments, etc. This kind of so-called agreement or contract is created between the two, which then guides a lot of the transactions. You then have the clients, so people who are actually then covered in the so-called insurance scheme. And here again, firstly, they have some kind of agreement with the purchaser, so the insurance agency. So for example, prices, so each member has to pay X amount, or family has to pay, or whatever. So there's quite a lot of also conditions which are then applied. And in return, for example, it could be an individual gets a coverage of 100,000, 200,000, or a family. So all of these arrangements as well form part of some kind of an agreement contract, which is then between the purchaser and a client. The conditions which are applied, which then again govern a lot of the transactions. And then of course, the transactions which are happening when an individual actually goes to a healthcare facility and seeks care. So in a nutshell, that's broadly what we talk about in terms of transactions within health insurance systems. And to split it up further, I would just do it in four kind of processes which are structured here around. So there's the enrollment part. So that's when someone comes into a program for the first time. Then you have the health service utilization. So once someone is insured and then actually goes to seek care, that's the health service utilization. Then there's the claim processing, which is really after, so the treatments are given and then the process of a health facility then submitting, for example, to an insurer, a so-called claim so that they can get some money back. And then the processes which are involved in that, scrutinization, payments, etc. And then you have the so-called renewal process. So obviously enrollments are for a fixed period of time, and then after that, a so-called renewal needs to happen, and what kind of transactions happen at that point. So while I cover here each process, as I mentioned before, there'll be a small poll. Just try to relate basically what I'm talking about to your context and respond to that poll, please. And once again, if there's any questions, please add them to the chat. All right, so I start here firstly with the enrollment process for sort of voluntary form, an informal sector or so. And here generally you always have to have, I guess in your context also you will be able to relate to this as an insurer, you always need to have some kind of outreach mechanism, because in this case, it's voluntary, it's open for individuals to join or not. And in that form, you might have to have an outreach mechanism where you reach out and inform, advise, and convince a particular individual or a household to actually enroll. And when this happens, as I mentioned, you don't have the information to begin with of who this individual is, as it's a voluntary form. So you might have some data transactions to undertake at that point. So you will have probably the need to capture some information, perhaps some way to identify the individual later, whether photo, biometrics, whatever. And some kind of, since it's voluntary again, and if the individual has to pay, then some way of capturing a payment which is done. At this point, then a lot of insurance schemes, based on the level of digitization, they then provide something to the client, which is, one is of course an identification, a way to identify an individual, so an ID card or so, which can have, I mean, depending again on the level of digitization in the scheme, maybe information is stored locally, so like biometric cards or so, or perhaps it's centralized, so placed in a central server or so, and the card is just a way to then link up this individual and retrieve information later on. And then of course, information around the policy or other relevant information, when do you have to renew, etc. Some of that information which has to be given to the client. And then of course, you need to have a way to take all of this back to the insurer, where all the information, once it comes together, the so-called coverage, the policy of that individual is then activated. You then have, in a similar way, another variation of an enrollment process, which also you probably can relate in your formal sector context, where perhaps you have some information beforehand. So for example, a company or so has to enroll their all of their employees into the insurance program, and they already know, who is the list of people who are part of their payroll. Perhaps the payment also is already given, or part of it is already given, as you mentioned in your context. So partially some information really comes in already to the insurer, and that's the starting point of the so-called enrollment process. Then maybe there might be a need for, as we said, if an individual has to be identified later on, how do you identify? Perhaps through an ID card. And this is somehow, again, the insurer needs to find a way, an outreach mechanism to then reach out, provide these to the individual. And in addition, also perhaps some additional information on what is covered. It's also possible that in some cases that you might have only partial information. And part of the information you need to also capture then during this point of contact. So the outreach mechanism then tries to reach out, visits a household, an individual, employee, and essentially then provides all of this, as well maybe perhaps capture additional information. So it's, as I mentioned, if there was partial information at the first point, or maybe an identifier like a picture or so is not there, or a biometric, whatever, perhaps that is also captured at this point. And of course, if there is partial information which is to be captured, then this needs to somehow come back to the insurer to again complete all the information on their side, and then activate the coverage of the individual based on your rules. Then the next part is now an individual has some affiliation, has entered an insurance scheme, has started their coverage, and how do they then go and seek care? So essentially, when an individual who is already insured goes to a healthcare facility, they obviously then go with some form of identification. So an insurance card or so, which is then used to really verify the membership. So this is really in terms of identity and eligibility. So who is this person? Is this the person who was initially enrolled into the program? What is their membership status? What are they eligible for? That information is then captured. And this again depends on the level of digitization that you have, on whether information comes directly there, if it's stored on a card or so, or whether it comes back from some kind of centralized server where you pull this information. Here, of course, as with any kind of program where you have identified specific beneficiaries, if you do have a valid card, then you're treated as an individual, as an insured person. Whereas if there's absolutely no way to identify this individual, if the person doesn't have a card, has an invalid card, they are not, perhaps the insurance policy is expired, so they have not renewed, for example, in these kind of situations, then they are treated as an uninsured client. In some insurance schemes, sometimes there is, I just added it as a kind of pre-facility check, but there might also be, again, depending on what the insurance scheme offers, perhaps a way to do some kind of check even before visiting a healthcare facility. Maybe schemes allow individuals to, in some way, to also be able to understand what kind of remaining benefits they have, what are the facilities they could go to, etc. When their policy is going to expire. So maybe some ways have to be enabled, some processes have to be created where an individual can then actually do that. So whether this is going to a specific point, an insurance office with a designated personnel who has an equipment or so who does this for you, or that you enable an individual to do it directly through some form of technology. So these are also sometimes processes which require some kind of digitization. And then you have, of course, the claims process. So the first part really around submission. So you have what's called the so-called cashless form. And in cashless, you don't have an individual directly paying, but let's say all the payments are done by the insurer side. So you have an individual which really goes to a doctor or so. Let's say it's a bigger facility, or it could also be that it's really a small facility. You just have a healthcare professional there, and the rest of the things like lab imaging, maybe it's an external office or so where this is done, or within a larger department or so you have this. Sorry, is there any question or? All right, I'll just carry on, but please do flag if there's a question or just type it in the chat. So as I was saying, an individual then goes to a doctor. Let's say the doctor suggests a lab imaging test or sees the results and then sends someone, the individual, to get certain drugs. Generally, what you would have is, it's the person, although goes to different departments in a large place or different places, but perhaps you have maybe a centralized billing or so. And in that case, even though the transactions happen back and forth, but finally all of this information is brought together at one point where the billing is then undertaken with the insurer, where some information is provided and something maybe comes back. There can also be the so-called pre-authorization cases. So you also have insurance schemes where perhaps high-cost events, certain surgeries, etc., require some form of pre-intimation to the insurer. So here again, it would be similar transaction, but perhaps a single point, let's say the billing or so, where some information then goes to the insurer and some kind of communication needs to come back before the treatment actually gets administered and the billing, etc., gets undertaken. And when all of this happens, then obviously there's a slight deviation also from this, that you could also have, let's say, a large healthcare facility, a referral hospital also, which might even have separate billing departments corresponding to their own different departments, say the outpatient departments, the inpatient, the lab department, pharmacy, etc., which do their own billing. And in that case, somehow you have to then bring all of this information back into one sort of claim. So this individual who comes in has all these different transactions, billing is done at different points, but somehow these have to be brought together then. And of course, once all of this is with the insurer, then you also need to, in some cases where there are certain ceilings, etc., which are applied, you therefore have to then update the remaining eligibility of that individual, whether it's on a decentralized smart card kind of a thing, or it's centralized in a server or so, but that information needs to be then updated as well. You then have a slight variation as well. You can have a similar case where an individual goes in, but in this case, it's a so-called reimbursement, which means that the individual essentially, for all the transaction, ends up making the payments. And once the individual does that, the individual then goes back to the health insurer and then applies for so-called reimbursement. So in some insurance schemes, it can also happen that they have this kind of payment approach where the individual pays and then gets the amount back. So all the transactions otherwise remain the same, but just the billing flow changes here. And then of course, at the end, as before, you have to update the remaining information on an individual's remaining eligibility. So that's really the processing part. And then what happens is, so as I mentioned, the processing is really this so-called submission. And then in any insurance scheme, there's never a payment which is directly done. And that's why you also have audit departments, verification departments. And here what you're doing is really a lot of checks, obviously. And I just cluster them into some things which can perhaps be done automatically and some things which require still some kind of a manual review. And some insurance schemes also require some additional procedures to come in, which then, because in the checks, you're making a decision. Maybe something is approved, something is rejected, something is partially approved. And some insurance schemes might require an additional process where perhaps this decision has to be reopened or re-questioned in some way. So there might be process flows there which require digitization. And then, of course, after all the checks are undertaken, then some kind of final calculation, what payments have to be made, and then a payment of claim. So that's on the claims part. And then the last process which I covered was really around renewal and modification. I add modification here because it's kind of certain use cases where changes might happen to a family structure, a newborn, maybe someone passed away, maybe a marriage, in or out migration into the family. And these kind of modifications are then initiated from the side of the family, who then indicates that there's a change and some new transactions might have to happen after that. So in a renewal process as well, it's here essentially you have someone who has been enrolled. You come to an endpoint where you have to do a renewal. So at that point, what you need is, if it's, let's say, again, a form where the family has to pay, then some kind of payment which has to be done. In addition, there might be some kind of information which might have to be captured at this point. In some insurance schemes, it's also possible, again, depending on the kind of identification cards. So sometimes these are collected back because they are time bound for whatever reason. And in that case, the ID cards might have to be collected. Some information might have to be given. And this is all being done through the outreach mechanism of the insurance scheme. Certain policy or other relevant information which is then provided. And then all of the information, cards, etc., whatever is collected needs to then go back to the insurer, who would then update and then again activate the coverage for this family from whatever point onwards. And in case, as I mentioned, if there is a case of issuing new cards or so, these are also done. And then again, the scheme has to go through their outreach mechanism and make sure that the families get these ID cards. The other form is again through, it could be basically on the other side. So the other flow, which is the insurer actually initiates the whole process. So the insurer might then, again, just looking at, say, the informal, the voluntary form, where The insurer then has to make an outreach to the family, again, kind of remind them, convince them, collect payments, etc. So here again, the purchaser, the insurer needs to then go to their outreach mechanism, somehow provide them some information and say, look, these are the people whose policies are going to expire, go and renew them. And then some kind of information has to be, perhaps additional information has to be provided, cards if they come in again, as I mentioned in the previous step, which is then given to the families. Maybe some information has to be updated. If not, just payments have to be collected. And then this again is provided back to the insurer to activate a policy. So the initiation in a renewal process can happen on both sides of this kind of a cycle, either from the family or from the side of the health insurer. So I hope at this point, maybe I just pause briefly and ask you, from what I've explained right now, is there any kind of questions here or comments that anyone might have? I think there's nothing in the chat, right, Cha?
Yes, Sir Siddharth, there's no question yet in the chat box.
Okay, you can also share the poll results perhaps at this point. And it's open if anyone has anything to add or comment.
Enrollment process, yes, coming up. Yes.
Okay, that's good to know. So a lot of you were able to relate the enrollment process also in your country context. So that was good. I mean, if again, like I said, please do add if there's anything to say from your side. But otherwise, I would just put one point across to you. Okay, I just see the second result. So the health service utilization process, you see everything. Everyone says that it's very similar to what you have in your context. For the enrollment, there was a small percentage, 25% or so, which said you're not able to relate to it completely. So here would be my question to really say, what additional processes or deviations which you see based on my description here, and compare to your context, where you think there are digitization needs. Please do let us know. I see here again now the poll for claims process. It seems everyone could relate to it. But if you find any kind of deviation or so, or some question that you might have where you cannot relate, perhaps just type it in the chat. I mean, either mention it now, or even if it comes up later, just type it in the chat. But otherwise, from the polls, I take it that you were able to really relate to these processes. Renewals, I see here again, some people were a bit unsure. And I would also then encourage you to really think about it and probably try to formulate what you think is different, or what deviation do you see. And I can try to maybe answer that, or just discuss it now, or perhaps later on. If there are no questions, is it okay that I move to the second part then?
Yes. Thank you very much for your very good presentation. Yes. I think we have many things that maybe the first point or second point that we don't understand, that we have to answer that. Yes. But I think we have also the enrollment process. Also, we know, because we experience that when we have community-based health insurance scheme, we also experience that. But now we don't have. We have that one very small area now. Yeah, and we have also the. I think the claim process that we have program with the National Health Insurance now, yeah, is the claim process, because we cannot go through e-claim system now, so we just go through the reporting system, then we check at the site. When we go visit the site, then we check at the site directly. Yes, and sometimes we just because we have the team at provincial level and district level, they can do the claim process also. So I think the claim process is another one that we need to improve here, because we have a lot of problem with delay reporting, delay transfer of money, delay claiming something. Yes, so I think this one is very important now.
Mm-hmm. No, thanks for mentioning that. And please do flag. You mentioned that there were one or two things which were not clear. Please do let me know if I can try to explain something better. I'll try that. But maybe one question about what you said with regard to the payments on the claim process. What kind of payment mechanisms do you have with healthcare facilities? Are you paying sort of fee for service, or is it some kind of capitation form? Do you have the need to actually go through each individual claim, scrutinize it, or is it some kind of bulk payments which are just made on, for example, number of claims or so?
Yes, I think we have two kind of payment mechanism here. One is a capitation payment for OPD, capitation payment for OPD, and we have a case-based payment for IPD. So for OPD, we just check the number just match with the number of the record or not. But for the IPD, we pay in case-based system, so we need to count the number. Then sometimes we have to check that is correct or not. Something, yes.
Okay, so basically with OPD, perhaps, I mean, just to generalize it a little bit, the level of scrutinization that you require is very important for the IPD cases, because you're doing really case-based payments are attached to that. And capitation, obviously, I'm not saying you don't need any scrutinization. You probably still need to know that it's the right individuals who have claimed, for which the claim, the right individuals who are insured, for whom the claims are coming in. You probably need some kind of scrutinization. So here as well, you have different levels which you require of going through each claims from OPD and IPD, right?
Yes, so we need, we need the clear report on that. Yeah, clear report on utilization. Yeah.
Okay. I hope then when we go through the process in the software, I'll be able to show you a little bit how it's done. Right now, I just explained in a kind of generic way that there's some level of checks that you can undertake sort of automatically, some basic checks, and there are some things which you still require some kind of a manual review for it. So when I go into the software, I'll explain some of these on how it happens and where. But I think that will kind of also give you an example of how also for capitation systems as well, case-based, how these checks can then happen. But that would come in the subsequent sessions then.
Yes.
Perfect. All right. Okay. Thanks for that comment. Is there any other comments, or is it okay if I move then to the next session?
Yes, you can move to the next session.
Okay, perfect. All right. So the second part here now. So the first was really, as I said, it was more to have the kind of exchange that we did have, so that you're able to relate a little bit, think a bit more in detail about processes, transactions, etc., which are happening. And now in this part, I will go specifically into openIMIS now. So now going into the system, it's this, and then next week, I think we have scheduled also 2 sessions. So these 3 combined, they are really trying to give you a demonstration or description of what openIMIS is and what it does, hopefully related also to your context. Right now, what I will just focus on in this session is really around this system characteristics and data captured. And I will mainly focus right now on access and reporting. So I had, I had quite a lot of topics here, but what again, in the event of time, I will basically talk about generally how data flows in the system. How do you access? And I will not talk a lot about what data goes in, because that I will cover in the next 2 sessions, but I'll really talk about what data comes out. So reporting and data analytics is what I'll talk about today. And then in the subsequent sessions, I'll cover these in more detail and basically just show you how beneficiary data is entered, claims related, etc. And also some of the configuration related data. All right, here again, this is why I was asking in case everyone can have a computer with them, because here the idea was I'll try to explain a little bit, but then really would ask you to try it out. So you also get a bit feel of the system and try to understand a little bit what I'm. Otherwise, it's just me talking and not a lot will register. So I would really urge you to please try to make sure that you all have a machine with you. The instructions will be given here, so you can log into your computer through any of your browsers, go to the demo server and just try out as I explain now in the subsequent session. So I'll try to break it up again. We'll try to do some kind of practical hands-on, but I'll also pause at different times for questions. So again, please type in the chat, or otherwise just stop me at any point and raise your question. So now going into openIMIS, specifically this one system. So in essence, the whole system, the main system resides at a central server. And this is really important in a way because a lot of transactions can be done in a decentralized manner at different points, and you do have a need for that depending on different schemes and how they function, etc. But it's also important to bring all of this. If there's too much decentralization, too many things happening at different points, it can also lead to some kind of incoherence across the data set. So you need a central point really where a lot of this information comes in, a lot of the logics come in. For example, if you change a price list somewhere, that needs to be reflected in a central way so that every decentralized point can be able to access that. So a lot of these information configurations, etc., they need to be done really in a centralized manner. And hence the main application essentially resides on a central server, which means all transactions can be undertaken just by having the system placed somewhere. And if someone has access through a computer, you can connect to the internet, use your login credentials, and based on that, undertake your transactions. There are some transactions which you can do using a mobile phone as well. And the idea is that, again, if you have internet connection, you can do these transactions directly with the phone. If by any chance your phone ends up in a village or in a location where you do not have proper internet connection, you can also then take that information off the phone, physically move it somewhere else where you do have internet, and then upload it into the system. And there's also the so-called offline component, which in some cases, some health facility, for example, who had a computer but did not have a continuous internet connection. They don't have it all the time, but perhaps they have limited packages, so they only switch on, switch off during limited times, or maybe the connections are just bad and they get disconnected. So what you do in the offline is it just allows you to undertake some transactions, so your operations don't completely stop. So for example, at the health facility side, they can continue to enter claims. They will not be processed fully, but at least they can enter on their side. And then when you can take that information, which is then entered on an offline, physically move it somewhere else where you do have an internet connection, and then from there upload it into the server. I mentioned the mobile phone application. So what does the mobile phone application do? There's mainly two different apps which we have. So one app is on the side of an so-called insurance agent or an enrollment officer. This is the outreach mechanism of the insurance scheme. So an individual who's then responsible for, firstly, the enrollment process, which I mentioned. So at that point, you have to acquire some data, or photos in this case, of each individual who's enrolled. So that part is captured in the phone app. You then have the part of renewing a policy. So the information can come directly also to the enrollment officer on their app, saying these are the list of individuals which are allocated to your location, and therefore please go and try to renew them, and then capture the information which is captured at that point. And then there is the part of so-called acquiring of feedback. So in the process flow, when you're doing a claim scrutinization, maybe the medical reviewer who's physically reviewing the claims might want to get some feedback from a patient. So the information at that point, they can trigger this, and the information automatically goes from the server to the mobile phone app of the enrollment officer who's responsible for the village where this patient comes from. So it's sorry, it's after the point, after the care has already been administered, the person is back home. At the point of scrutinization of the claim, this feedback can also be captured then by the enrollment officer going to the house or the individual where the patient is and asking for this feedback. And then on the health facility side, the app basically is used to first of all, retrieve some information on the individual. So who is this individual? What kind of eligibility do they have? Are their policies active or not? This kind of information can be queried, as well as then submission of a claim, which can be done completely on the phone. So what treatment was given to the individual, all of that can be captured and then submitted to the insurer for payment later. And essentially, as I said, there's two apps, two mobile phone apps, one on the enrollment officer side and one on the claim administrator side. And these different functions you can perform from the mobile phone app. With the mobile phone app as well, how the data flow happens is basically, as I mentioned, there's a central server. For any person to undertake transactions on the phone, you firstly need some starting point. So if it's an enrollment officer, they need to know how much an individual or a family who enrolls is supposed to pay. When should their starting point be, etc. Locations, the list of villages, etc. that they are responsible for. So some kind of master data is, if the phone has connection to the internet, this information is directly synced into the phone. And after this point, the enrollment officer essentially enters their so-called code and then just does the data entry. And this is all done on the phone without any internet connection. So it's only for this master data you initially need this. And once all the data entry is completed, whether it's one family, 10 or 50, at the point when they have to synchronize this data, upload it into the central server, that's the point where they need some kind of login credentials, enrollment, an ID, a password or so. In case, as I mentioned, it's still possible that phones perhaps land up in places where there is not a proper internet connection. And in these kind of cases as well, one can then create a similar so-called extract from the central server onto a computer or so where you do have internet. You then physically move it to the location where this phone is added to the phone in an offline format, so without any internet. Continue doing the transactions as I mentioned. And once the transactions are completed, if there is no internet connection to upload, you can also then take the extract out to another place where there is internet connection, and then using your logins, then upload the data set into the central server. So that was the mobile phone apps and how data flows through it. This is what I mentioned, the offline component. So this is in a case where, let's say a health facility, as I said before, has a computer. They have a local installation on their computer, which allows them to continue their transaction. So here again, when you have, you will have to firstly connect to the central server and firstly download a so-called extract from the central server, which then you physically transport to the place where you have this so-called offline client, an offline computer without any internet, and you upload the data extract into it, and then you undertake your data entry completely offline. So at this point, no internet connection is needed. After you complete the data entry, again, this can be, or if it's at a health facility, it can be after whatever claims for the whole month are entered. So you have 100, 200 claims. You then download all of this data and you physically take it to a point where again you have internet connection, and then you upload this data set. So this is how similar logic, mobile phone and offline client, how they function in a online as well as in a offline setting. All right. Is there any questions at this point, or should I move to the next part. Okay, and the polls also are shown here. So just to mention, so Claims app is used for, as I mentioned before, it was only 40% who said for inquiring about an individual's eligibility and claim submission. That was the so-called right answer, because the other parts, so capturing feedback, this, as I mentioned, the feedback is actually captured by the enrollment officer. So the first option was not right. Claim submission is correct, and renewals as well is done by the enrollment officer, not by the claim administrator, which uses the Claims app. And the other question about at what point in the mobile phone apps does the user need to enter their password? So only a small percentage says when the data is uploaded. So this was also to highlight that transactions can be done in an offline form. So the first option, which most of you said, when a new household or a new claim is entered, you don't need to have any password at that point. The point where this verification is required that you are authorized to actually do this transaction is when you actually put the data into the central server. So when the data is uploaded. All right. If there are no questions, I think I'll move on to the next part. So this was really about an overview of how data is flowing through the system. Now I'll go specifically into access. And access to openIMIS is basically based on what we call role and location. So location is really the geographical location. So depending on which location you are responsible for, your access is defined by that. And you're not allowed to then look at data or information for another location. And sorry, go ahead.
Sorry, yes. I saw the one point that you said that during the offline session, can we upload the data to the server? When
in the
offline system.
Yes, so in the
we need internet connection before upload, no?
Yes, exactly. You need the internet connection. So the both the examples which I showed here with the offline as well as the mobile phone, you do need the internet connection to upload.
Yeah, we need. Yeah, and how about central server? If we use this system, central server we need to hide or not?
Whether you need to, I didn't get your last point.
No, central servers. Yeah. If we use this system, we need to hide the server, to buy the server or something, no?
You will need to set up a server, yes, on your side where your system will reside. You can decide to either buy it off some other service, or you can decide to host it in your location. That's up to you.
Okay.
Yeah, there are insurance schemes which host it locally as well.
Like a web-based that we use now, no?
Exactly.
Okay.
Yeah, it's a web-based application, exactly. Yeah,
Okay.
yeah, that's the right word. Maybe I didn't use that. It's a web-based application, yes, with some transactions, as I mentioned, which can be done in an offline form.
No.
Yeah, so what I was just flagging here was that at the point that transactions can be done in an offline form. That's what I was trying to flag with these steps, that on a mobile phone as well in the offline form, you can do transactions, enter data.
ข้อมูลซื่อๆเวลามีอันนั้น connection แล้วจังค่อยอัปโหลดได้เนาะ offline หมายความว่าเวลาเขาป้อน offline ได้
Yeah, so you can enter data in an offline form. It's just when you upload, yes, you will need internet. So either you do it when you have internet on the phone, or you take the extract somewhere else and then upload.
Yes, sir. It's the same system that we have now. We also use the offline. Then when they have internet connection, they can upload to the system. Yes.
Yeah, exactly. So it's similar logic here. All right. Okay, is there another question? Shall I move on? Okay, I'm guessing there's internal discussion, so I'll just carry on, but please stop me if another question comes up. So as I was mentioning, location, there's different levels within the location. So we have up to 4 different levels, which I'll come to and explain. So geography can basically be described on the system in these 4 different levels. We then have so-called profiles to define what these roles are. So we have some kind of system defined roles, which we saw across different schemes. So it's kind of generalized, but you can also create additional profiles if needed, where you can say an individual is then responsible for these tasks, or these can view these aspects or edit them, etc. And then you have the actual user count creation. So an individual then is created, that's a user in the system, which is then allocated a particular role and a location. So I'll go now into how this is done. So if you go to the demo, and I hope you will go to the demo server, you'll always find this login name and password right now, which we've already added. So as I mentioned, there's a user with a user ID and password which logs in. And the first thing that you see in the landing page once you log in is really this part on the top left, which I've highlighted, which is really around roles. So firstly, you see this particular user has multiple roles. So this person is also an enrollment officer and a manager, an accountant, etc. All of these roles are allocated to this particular role. In addition, this person is also responsible for multiple locations here. So many regions, many districts, which are falling under that. So this way you can really construct, you can also have an individual who has just one role and is responsible perhaps for just one location. So based on this, like I said, role and location, you create a user login, and their access to the system is also then governed by that. So I will only use screenshots here, but in the session where we pause briefly for a short exercise, I will ask you to really go to the interface and try to do it. So I hope you will be able to navigate yourself through this, and it's also a way to understand how intuitive kind of this whole system is and how helpful the instructions is. So basically under administration, when you log into the page, you have this thing called locations. And in the locations, as I said, you can go down up to 4 different levels. So in this case, the labels here, these can be changed according to the country context. But here it just says the 4 levels being regions, districts, municipalities, and village. And these can, of course, then vary depending on your location. But the system basically has these 4 levels which you can configure to geographically define your scheme into the system. And this helps if you're also doing, for example, step-by-step rollout. So you start with region 1 first, and then maybe 6 months down the line, you start with region 2, etc. You can essentially build the geographical outreach of the scheme using this. And when you come to this, I would just flag that when you go down to the last level of village, when you're creating this, it also will flag, I mean, it has some extra data entry fields, like you can enter the number of individuals, male, female, etc. in a village. This is not needed if you don't need it. This is just in case that in one scheme, for example, in Tanzania, they also have a formula which they apply where they give weightage to the catchment area of a health facility. So a health facility is allocated to certain villages which they are supposed to cater to, and the population of the village then influences their payment formula. So this is why you'll find also this kind of additional thing there. But just to keep it simple, you don't need to worry about it. You can just in your exercise just add the village level, and it's non-mandatory. The next thing then that I mentioned was user profiles. So here again, if you go under administration down to user profiles, you'll find something like this. So I mentioned to you before, there are some standard roles which we are already defined in the system. So for example, the tasks which have to be done by an enrollment officer, manager, accountant, etc. These have all been kind of system defined roles which you will find already there. And this is what this indicates, this thing which I flagged here under system, which also is true. So these are all system defined. But as I said, you are also free to, you can add more profiles here. So one example I do is always give here is, for example, some schemes have an additional, maybe an external donor or so, which is subsidizing something and would like to directly look at, have a way to look at certain reports, for example, just in terms of how many people were covered in a location which they were providing support to, as an example. So they can create some of these additional roles and then allocate certain reports, for example, for them to access. This is what it looks like. And as you see here, you can basically indicate with these tick marks. So these are the different modules which you see on the screen also here, insurees, claims, etc. And within that, you have the different sub pages and what are you allowed to do in those sub pages. So you can define these, and what you will find for the system defined roles which are already there, you will find that these are already selected. And this is how you can then define a new role as well and indicate if you want some specific access to the person or specific tasks which this person needs to do. Now, I mentioned two apps. So I'll specifically talk about creation of users firstly for those two apps. So this is a different entry point into the system, which is specifically flagged here as enrollment officers and claim administrators. So the first thing is, again, under administration, you will find this enrollment officers. So this is one type of user which does the task which I mentioned before, enrollment, renewal, feedback collection. And here, this is, I guess, like quite a lot of other user accounts that you're creating. So you create an enrollment officer. The enrollment code is important because subsequently this becomes the kind of login for this individual. And as you see here on the bottom right, you don't forget to select that to include a login. So you can create a password for this individual. And this individual then, when they log in later on, that the code becomes their user ID and the password you enter becomes their password. And as you see here, it's some standard information on the individual. You have the possibility to then allocate specific locations to them. Maybe they're responsible specifically only in this example, what you see here, for one village in a particular area. It could also be they're responsible for more. There's this thing called substitution at the bottom here, which is to just say if you have 100 households related to an individual who has enrolled these 100 households, and perhaps the person then stops working. So you can indicate it here that this person will stop works to this point, and after that date, everyone gets shifted automatically to the substitution, a new enrollment officer. As I mentioned in the apps, we won't look at the apps, but just to give you a feel for it, in the app as well, this is, as I mentioned, all your data entry you do using your enrollment officer code, and it's only at the time when you're uploading any information to the server, when you're communicating with the server, that's where you require your login ID and password. That's for the enrollment officer. It's very similar for the claim administrator. So again, under administration, claim administrator, you find something similar. So in this case, claim administrators are always allocated to a healthcare facility. So that's why you don't have locations, but rather health facilities where this claim administrator is allocated to. Similar information, again, adding a password there. And here again, for the claim administrator, then your code becomes your login ID and your password here becomes your password. And again, like I said, claim administrator code is what you need for all the data entry, and your login details will then be your ID and password. And this only comes in when you're synchronizing data, when you're communicating to the central server, to the web application. These are the two key roles related to the apps. Now you have also other users which might be using the system, managers, data entry operators, etc. And these also you can create from administration users, where you go and you indicate similar information, and you can then indicate also what kind of roles they have and what locations they get. All right. I would stop at this point, and as I mentioned before, I hope most of you at least have a lot of a machine, a computer that you can really try this exercise. You can ignore the first part here. Let's just stay here in one group, but I would ask you to log in from your computer. Go to this server which you see here, demo.openimis.org. The login details are already there. You just have to log in, and I would ask you to do these 3 steps basically. So firstly, if you go to the locations, add your own location and try to add with all sub levels. If you have questions, just please ask. I can also try to log in on my side, so on the screen you can see it. But maybe I would ask you to at least give it a try first on your side and try to add firstly a location just from your side. Put in one of your regions, break it down to a village level, at least add one at each level. Maybe add your initials because multiple people will add this now, so just so that you can identify it. And once you do this, go to users and add an account for yourself. And when you create an account for yourself, just give yourself the 2 roles that I mentioned here as a scheme administrator and an IMIS administrator. And once you have created this, please remember the user ID password. Just log out, log back in, and now use your own account. And then see for yourself what kind of access you have in the system. And at that point, create an enrollment officer for the location that you have created in the system. I hope this is easy enough, and I hope you're all trying on your side right now. I'll be around. I'm just placing myself on mute, but I'm here. If there's any questions, please ask. And let's take maybe, as we said, 10 minutes or so, and then I'll continue after that.
Hi, Siddharth. This is Alvin.
Hello, Alvin.
Sorry, I came in late. So I think while the others are doing their practice rounds, I wanted to ask what would be the minimum number of people a ministry would need to administer an openIMIS system in their MOH?
It really depends in terms of what kind of structures, etc. they have in place. I can give you an example of a small scheme. So say a small community-based schemes in Cameroon or so, they operate on the insurance side. So I've shown you quite a lot of different roles. But what they do is on the insurance side, they essentially have a so-called data entry operator who does a bit of the data entry related to enrollment. And if claim forms are coming on paper, they do that entry. It's one person. And then they have perhaps a manager who then looks at reports, goes back and looks at every month what's happening. So they have an access. And generally they have some kind of person. It's generally the data entry person or an IT person who also supports them with configurations. So you do need someone who understands the system a bit better. So what I'm talking about here, you need a lot of administration on this side. New user accounts have to be created, maybe new health facilities have to be added, etc. So generally you have a so-called administrator for this. But then it really, I guess for the health insurance board here, they have probably a separate verification department, an auditing department.
Right.
So you would need like a medical advisor is a separate role where they're doing verification of claims. They might have auditors who do the kind of accountant role where they look at what payments came in, what went out. And maybe they don't do maybe data entry at the office level, but perhaps they have outreach officers, agents who do the data entry for them for enrollments, and maybe health facility does the same for claims. So there it really depends on how their departments are structured and how they are using this. But as I mentioned, the different roles, that's something we try to structure from our side. It doesn't mean you need to have one person for each role. A lot of times it happens people combine certain roles depending on the scheme functioning. I hope that answers your question.
Thank you, Siddharth.
While we are waiting here, I'll just answer. There was also one question, I think, about the application in Lao language. Yes, you can. We don't have a use case for it unless Ahin has tried this, but we do have the system. Basically, we've created also these kind of label files, etc., which we have, and we have translated the system into other languages. So we do have, for example, the demo server that you see, you will see it in English and in French. And the same way, like in Tanzania, they also have the Swahili version. We did a small feasibility mission recently in Myanmar, where it was also translated then into the local language, just in a rough way to show this. But of course, if you have colleagues who can really verify translations, etc., it's not very difficult to do that.
That would be a project, right, Siddharth? If converting openIMIS right now into Lao language would probably require at least one person.
Yes, I mean we have we've set it up now at the initiative level. We are trying to use a solution called Localize, so it's all online.
Yes.
We've created the resource files over there, and yes, we can also start with some kind of basic translator. That's how we started also with French. But you still need a person who understands the context, the business in a way, to also verify this information.
Yes, we have a small set of funds at AHIN to actually hire somebody to do that localization, but we'll need the help of the Laos Health Insurance Board to select that person, just to inform the insurance board over.
And we would be happy to help out in this process to explain to you how to do it, etc. But yes, if there's an individual identified, it would benefit quite a lot also the community then. Someone asked a question about interaction with other systems. I'll maybe we could do it. We'll answer it at the end, and I'll also ask then Saurav to just chip in a bit and explain. I'll also cover one of these interactions. So DHIS2 I'll mention at the end of this session. But also perhaps at that point we can just stop and talk about the other interactions also with other systems. So I'll just log in as well, and let's see. I hope some of you have at least managed to enter. Yeah, I see here some locations. If you can, I would also encourage you to just try and add within the region as well a district. So as you see on the screen here, you have a region, you can add another district under it. And the same way you can go down the levels, municipalities, villages, etc. And I hope you have also reached the point. I hope someone has. Yes, I see someone. Oh no, that's from before. Yes, there's one person who has created. Excellent. An enrollment. Yeah, exactly. So you have here this enrollment officer for this one specific village that you've created an account for. And I hope you created this login as well, because that's the password and that's the ID, login ID for this individual, then this account. You can also log in with this account and see what you have access for. And let me just check if anyone added a user. Yes, I see a couple of users here. Exactly. And if you log in here, the point of showing you this was that you really need, as I mentioned to Alvin as well, a person who manages your so-called registers. So if new things are covered in the insurance scheme or new health facilities are joining, new users are coming in and out, you need someone to be managing these registers. And that's basically what you get with these roles. The scheme administrator, you can create new user accounts, etc. So that was the reason to ask you to really try out these aspects. I think slowly let's try to come back, and I will also shift to the slides then.
So it's like Siddharth, you need at least like a person to be roles and responsibilities to other people, right?
Exactly. And when you say what kind of roles are required, like I said, it depends on the structure, but generally the suggestion would be to definitely have one person who's more knowledgeable and really centrally manage this administration role. So having someone who then creates, because it also causes a lot of problems if you have, for example, new facilities being added by lower levels or different districts or so, because it creates a lot of inconsistency in the data. Yeah, it's generally recommended to have a single person to do the scheme administrator role centrally. So the creation of additional registers, health facilities, etc., it's better to do it in a centralized manner. All right, I think should move on. I'll carry on now with section 3 and would ask you to please type in your questions. Also, the demo server is there, so please go back, keep playing around with it. And if there are questions, just come back to us. I think what we will do is perhaps, or maybe I ask Saurav if it's okay to maybe share the link of the wiki page with these sessions and the details on it. And perhaps that's maybe a way to, a way for you to then communicate back with us. Just feel free to add a comment at the bottom of the page or so if you have any questions or so, and then we'll get back to you. And that you can then make it specific also to the respective section that we are talking about, the session we are talking about, if you have questions there. All right, so I move now to section 3. As I mentioned to you before, I will, in the event of time, just go straight to the last part, because what data goes into the system, this I will cover anyway in the subsequent 2 sessions. Configuration related as well will be in that session. Part of it we've already started. So configuration related is how do you set up a scheme on the system. So as I mentioned, users, claim administrators, enrollment officers, etc. That's part of the configuration as well. And I covered that under this, how to access the system. So the rest of it I'll carry on doing there. Now what I will focus on is just the reporting and data analysis. So what comes out of the system. So you have all the different transactions which are happening in the system. I think as you are all also working in the health financing space, the health insurance board, you already have some idea of what these transactions are. We've discussed it before. And then the question always comes about how do we then monitor the scheme. So there's obviously different needs of it, different needs from the system of what you want to look at. And what we have in the system then is something that we created, which was really the standard operational reports. So there are some things which are very standard, which are very common across schemes. So we've tried to create them as standard operational reports in the system. And then we have the so-called customizable reporting options. So there were, of course, then additional needs to do more dynamic analysis, to do more analysis across different parameters, etc. And here I'll explain one of the connections which we then have also with DHIS2. So firstly, reports. Again, if you go into the system, you basically have under this tools what you call reports, and there's quite a lot of different reports here. For each of these reports, you have different types of filters depending on the kind of report it is. Some things, it makes sense to look at it daily, some things monthly, quarterly, whatever, by product, by district, region, whatever. So there's quite a lot of these filters which are then specific to each of these reports. This is just an overview of the list of these standard reports which are already there in the system. And these are all covering different aspects which are undergoing, the different aspects which are being covered by the system. So the management of families, insurees, individuals, policies, premiums, claims, etc., which you're looking at with all the data that's coming into the system. So you have the operational indicators, so around policies and claims. So really on an operational level, how many policies were sold, renewed, how many claims came in, approved, etc. All of this comes in here. There's then the so-called derived operational indicators. So these are more derived indicators, for example, renewal rates, etc., which are calculated and then provided in the system. Then, of course, contribution collection. So really a description of what kind of money is being collected by location, agents, product sales. So this is something which might also be important to keep track of, considering also your agents. In some cases, they are on commission basis or whatever, or you want to generally monitor the performance. So across agents, what kind of sales have happened, and more details in there. I'm just giving you some idea of what these reports are, but there's more information in there which you can look at by going into that interface. Contribution distribution, this is really around one context where the payments basically were dependent on the amount of money which was collected. And in that kind of mechanism, it gives you an idea of how the money is being distributed across a period of time. User activity report, it's very standard, kind of a log of who logged in, logged out, what kind of transactions they undertook. Enrollment performance indicators, so these are all to do with enrollments, splits by gender, etc. You find all this information there. Status of registers, so just in terms of all the configuration parts, how many health facilities, etc. All of this, you can get a status update. Insurees without photos, this was happening in some context where photos were allowed to be sent to the system, but then data would not come in. So to be able to track that, if that has happened, so you can check that. Matching funds was something which was related to an external funding which was being provided, which had to be accounted for while paying for claims, but it wasn't attached to an individual's payment which was done. So it came externally, dependent on the outreach of the insurance scheme. External payment comes in, but then yeah, it's a different way of entering the data into the system and then showing reports out of that. Claim overview is, of course, what kind of claims came in, what was approved, rejected, reasons, etc. Percentage of referrals is really in context of referrals, some splits there. Family and individual overview, so who is in a family, what is their status, etc. Pending insurees are individuals. A lot of times it happens you enter data, but then the families were not activated either because payments were not completed or whatever, so this is to keep track of that. Renewals, as I mentioned, all related to renewals. Rejected photos are basically photos which were sent and not, for some reason in the web application, there was some conflict or so the photo was never allocated. So this also allows a way to go back and track it. And capitation payment is then an approach which is being applied in Tanzania, for example, where they have a particular formula which gives weightage to the population in the catchment area, the number of claims which come in, etc. And all of this, then the parameters are basically calculated in this capitation payment report. So that's the standard reports. I mentioned to you there's different filters. So as you see, they vary according to the different reports. And all the reports, the standard operating reports, operational reports, you can then export all of these out of the system in Excel, PDF, Word, whatever format. So this is the standard bits which are existing in the system. In addition, we have the customizable reporting option. So this is where I mentioned the link to DHIS2. So all the transactions which I mentioned till now were on the right side of this diagram, where I scroll my mouse. Basically, an individual coming in, enrolling, claims, etc. All of this happens, and the data is basically stored in an operational database on openIMIS side. We then have a so-called FHIR reference module, which is then connected to a DHIS2 FHIR adapter. So we are following this FHIR mapping basically to get data out of openIMIS, and the same way map it to DHIS2. And in DHIS2, the data gets sent into a so-called tracker. So individual cases on the side of an individual, the enrollment data, and then on the side of claims, each individual claim then goes into the tracker, which then gets aggregated. And then you have the so-called dashboards on the DHIS2 side. So this is just an example of it again, of what kind of figures, etc. one can then visualize. As DHIS2, probably a lot of you might know this, has a good interface of, you can develop charts, visuals, maps, graphs, etc. And I put in a small link there at the bottom if some of you are interested. There's also a test instance with a demo dashboard which uses some dummy data to give you an idea of what kind of figures, etc. can be, graphics, etc. that can be generated. So I'll stop at this point and maybe just open it up. And if you have any questions, please do raise them. And otherwise, Cha, is there anything coming in the chat?
Yes, there's a question from Dr. Daniel. So can the web browser and computer be used offline?
Yes, on the computer, as I mentioned earlier, there is the so-called offline component, which allows you to do some transactions. So on the enrollment side, for example, if you have an office and maybe you don't have a regular internet connection or so, and let's say enrollments were being done on paper and the paper forms comes in, that's basically in the offline application, you can then enter all of these applications into the system without an internet connection. And the same way at the health facility side, if let's say you have all the claims captured in a paper form and you have an offline installation of the application, you will be allowed to enter all the claims onto the system. But for subsequent processing, you of course then have to upload the system. But these are the two key aspects which you can do offline on a computer.
Thank you, Sir Siddharth. The next question is from Dr. Virasak. Is there a mobile app or just using web browser in the mobile instead?
So there are two specific mobile apps which you have to install on any Android application, a phone, a tablet or so, you can install it and use it. But these are two separate apps. Enrollment officer side for enrollment tasks, as I mentioned, and then on the claim administrator side for the health facility side, so to do verifications and submission of claims.
Thank you, sir. The next question is from Dr. Bonlam asking if openIMIS is customizable, but I'm not sure which part. Maybe Dr. Bonlam can unmute his microphone.
Yes, just my question is just want to know if this system could be customized in terms of for example, if you want to adjust something inside the system. This means the user can customize by themselves, or do they need some more technical support? That is my question.
So, I mean, I would again go to really what you want to customize. So there's things like, labels, etc. You maybe don't want to call it insurance ID. You want to call it something else. Maybe you have a different logic for the unique enrollment ID that you have, etc. So Right now, also in the different countries, they are applying different labels, they are applying some different logics. So the verification of the uniqueness of the ID number, it depends on the country. They're all using different logics. So these are things which are locally done. Some of these things do require a bit more technical knowledge. So it's not from the front end side. You will need a person who configures. So at the time of installation of the application, you are also able to adjust some of these things. And we also have subsequent sessions which we'll do. This is what we called module 1. There will also be a module 2, which will be really around installation and country customization of the software, which will be done at a more technical level. And there they will also, they can describe to you the different steps on how some of these customizations can be done. Also, like enrollment, what kind of fields you want. Maybe you want to add I don't know, the number, the license number or something, driving license number or whatever. These kind of things also you can add that. But a lot of these will be then covered in that module, but they do require a bit more technical knowledge. It's not from the front end side.
Yeah, thank you.
If you don't see anything else, maybe I'll come back to one question which I picked up in the chat, which was regarding the interaction with other systems. And maybe I can start, and I would maybe ask Saurav to just chip in if I missed anything. But what I mentioned here now at the end, so interaction with other systems, the whole effort from the initiative side has also been to really make the system more modular and make it capable of communicating with other applications. So what I mentioned here in the description also of the integration with DHIS2, the whole emphasis was really around firstly this so-called FIRE module. So it's more a standardized approach of interacting with other systems. So the first thing has been from the initiative side to make the system compliant with this FIRE standard so that data can really be exchanged with other systems. And once this is one of the steps which we are doing, and using that, we were able to then make an integration with DHIS2. The same way, there's also integration works which have been done with, I think, with Bahmni. So more kind of hospital management systems, patient record systems. With Bahmni, with openIMIS, that's what comes to mind. So these are the key applications I can tell you right now where there is a clear, an existing use case which has been developed. So DHIS2, openIMIS, Bahmni, mapping has been done through this FIRE reference modules. And there will be more applications that we are looking at in the longer run. But these three, I can at least tell you, there is an existing use case, and these are all also documented, and more information is provided on our wiki. And I would ask, wiki page, I can drop it otherwise from my side in the chat here. But I would otherwise also encourage you, you can write to us and we can give you more information. But the wiki page essentially has information also in all these integrations that you can have further look at.
Thank you, Sir Siddharth. We have one more question. So if we need to apply this system, what is the process that we need to follow?
The process, so as we mentioned, it's an open source application. You're free to download, customize it, use it the way you need it. Maybe one more small thing to add regarding also your comment before about this claims module and that you need a lot of support. Perhaps this solution, maybe you find it interesting for specifically the claim management part. Just to add that in terms of modularity, that's been one of the efforts to make the system more modular, which means you can also then look at really just the claim module part and not the other parts in the system, and then integrate that with your existing application. But we would encourage you to really do that again through the FIRE resources, the mapping which has been done, based on which we are doing integration with other applications that I mentioned, but also in your context. So now coming back to the question about how do you go about using this application? So the software side is really, as I said, it's open source. You have it there, you can do what you want with it. In terms of practical implementation, we've also tried to document some standard steps, which based on our experience in different countries, we've tried to put in a nutshell some kind of flow on how you go about setting up, applying the system to your scheme. So we really encourage what's called a so-called assessment and planning stage, where you look at your scheme design, scheme operationalization. This perhaps in a lot of cases is already done, and in your case, you already have something in place. But based on this, you then do some kind of assessment on what part of the software is applicable to you, and perhaps maybe something need changes, etc. And that's where what we call the adaptation phase, where you try to do some customization setup, and then head towards any kind of training, and then leading to a pilot, and then further scale up. But I'll drop this in the chat, so there's more description about these steps on what we encourage on how you can take this up. Are there any other questions?
Yes, there's another question here. It's from Dr. Daniel. So to enable offline transaction, do we need to install specific modules in the computer, like EXE, or no need to install anything?
That's a good question, and I would ask you to definitely join module 2 for this, because that's where we give the details. You will have to, it's basically the same application that we have online. You have to install it on a local machine. So there are some components, yes, which you would have to install or enable in your computer, in your offline application in order to use the system. But more details would be there in module 2 then, where we talk about installation specifically and country localization.
The next question is from Dr. Eek. If we want to share the data with DHIS2, must we have the same server?
It depends really on how you set it up and what kind of loads, etc. you have. It's possible just to keep it a bit free. You might want to have different locations where you really set this up. But I would think in general for bigger schemes, it's better to have 2 separate servers for this, because you have quite a lot of transactions which are happening in any kind of largish scheme. You will have quite a lot of transactions which are happening, and then all of this data which is being captured on really not just daily, but literally by the minute, which is coming in. There's quite a lot of transactions which are happening. Reports are being generated, etc. And it's always better to keep that on a separate server. And then with the flow which I mentioned, you basically set a frequency for it. Is it every day? Is it every 2 days? Again, depending on the amount of data that you get, you might, and when you put your frequency, the sync will also take some, will kind of, be a lot of pressure which you put on your server. So it can slow down certain things, again, depending on the amount of data you have. And you would need to do more optimization. But generally, I would think probably if you have larger schemes, it's better to have separate servers.
Thank you, sir. We also have a question from the team. So the NHIB developed ATD system. How can we integrate this with openIMIS?
I wouldn't know the details of the ATV system, but what I would suggest is probably really the starting point would be firstly drafting really the scope of what your application does and what you would want to use from openIMIS. And once you have that scope drafted, really look at the FHIR mapping which is being done. So if your application is compliant with the FHIR mapping, you will find it much easier to make the integration, because on the openIMIS side, that FHIR mapping is already done or almost done for most of the application. So I would say probably that would really be the right step to try and look at that. And this details here again, I can drop a link maybe here. Let me just type it into the chat. But you can also go back to it and look at this, the wiki page which we set up on the FHIR mapping, and that would really be your starting point to see whether your application is mapping with that.
All right, I think that is the last question, Sir Siddharth. So before we go, may we hear some words from Sir Siddharth and Dr. Alvin?
Yes, me first. Thank you, Siddharth. You'll have the final word. This is Alvin Marcelo. Thank you very much to our colleagues from Laos. We look forward to the future trainings. As I explained earlier, if you think the localization of openIMIS will be useful for you, just let us know. We have actually a few resources that we can use to help you with the localization. Again, in the Philippines, we have a very sophisticated health insurance system already. I was a former CIO of that. But we're using openIMIS now to educate our medical students on what is a health information system and how a health information system supports a national health insurance scheme. So for us, that has been very useful, openIMIS as a learning tool Um, I like it very much that openIMIS is interoperable with DHIS2, because I know that Laos is one of the more mature DHIS2 users in the region. So if that's already possible, then there's a lot of things that we can reuse from DHIS2 that you can put into openIMIS. So we're here to support you. Let us know how we can support you from AHIN side. Siddharth, your final words before the next
Uh,
session, of course.
Yes, thanks, Alvin. And just to wrap up here, on my side as well, thank you very much for your time and for having joined the session. As we said, we've now gotten into the system with some bits, and in the next 2 sessions, there will also be some hands-on that we'll do. So again, would request you to please have your own machine so you can try out, practice things. Yeah, and thanks a lot once again.
Thank you very much. Bye. Thank you, Cha.
Thank you.
Thank you very
Bye-bye.
much.
See you in the next session.
See you next session.
Bye.
Thank you. Bye.
Goodbye.
Thank you.
Thank you.
Hi, everyone.
Bye. Have a nice day.
Thank you. Thank you very much.